Okay, good evening, everyone. Good evening, thank you. So today I'm so excited to introduce you. Ifrad is one of our most successful alumnus. So he will let you know about prospect of your majors, the job market, and his success story. So without further ado, I just let him to come and introduce himself and let us know about his today's presentation.
Awesome. Thank you, Professor Hamid. Let me just make sure I get this. So I'll share my screen. Okay, awesome. All right. Well, hi everybody. Good evening. Thank you for having me. I'm really glad we can make this work. I actually went to Clark a few years ago, many years ago. Graduated maybe 11 years ago. I only live 2 miles up the road, but I don't get to visit campus very often. I actually only visit campus over the summer when no students are around because I like to walk my dogs around campus. They love it. But it's really great to be back. Professor Hamid and I connected over the summer, and we felt like it would be a good idea to kind of come into a class like this and talk about applied analytics, right? How you can apply some of the skills you're learning and some of the content you're picking up in the real world. And also learn a little bit about the job market around business analytics. I know you're all very interested about that. So let me tell you a little bit about myself, and then I'll kind of go through our learning objectives. All right, so I was born and raised in Bangladesh, little country beside, right next to India. This is what I look like underneath my mask, and when I get a professional haircut, not a buzz cut for my wife. I came to Worcester about 15 or 16 years ago. I went to Clark University for undergrad. Then later on, I did my graduate studies while working part-time at Northeastern. I worked for a company called Optum. Now, between graduating from Clark and Optum, there was a little bit of gap. There was a gap of about 7 or 8 months. I had an internship at that time. I did an internship with National Grid. It's the power and utilities company. It was like a 3-month internship that turned into a 6-month internship. My boss was being really nice because he knew that I was looking for a full-time job. 2010 is the year I graduated, which some of you might remember is 2 years after the great financial recession started. So it was not a good job market. I applied to 123 jobs. I got 6 interviews, and I got 2 offers. I was a foreign national too, so that made it a little bit tougher. But that's just giving you an idea about the scale that I had to, the extent I had to go through in order to get a job, get a full-time job. So 2 offers, one from an energy consulting firm near Boston, and the other job offer was for a healthcare company based in Worcester. So I thought about it a lot, chose Worcester, and here I've been ever since. I live in Worcester with my family that comprises of my wife and my 2 dogs over there, Liam and Figgy. A little bit about me. So what am I doing here? Why am I here? I want to go through some learning objectives. So I work in healthcare, have been for about 11 years now. So I want to tell you a little bit about how the US healthcare system works. You'll need that background in order to kind of understand the applied analytics piece of it. So we'll talk about why we need data analytics in the healthcare industry. I want to show you some examples. I know you've been working on data visualizations and statistical analysis quite a bit. So I'll show you some examples of visualizations and problem statements that can be solved using analytics in the industry. But most importantly, I want to connect the dots with the profession of healthcare. I know that many of you, maybe some of you are already employed, maybe many of you are going to be looking for jobs in the future. So I really want you to kind of think about and keep thinking about the profession of healthcare and if it's something that you're actually going to be interested in after you graduate from your program. Also, just to be like perfectly honest here, many of you may be graduating and looking for a job without much experience behind your back, right? Some of you might have internships, some of you may not have any internships or any work experience. That's okay. one of the most challenging things about that, though, is when you're interviewing with an employer, you need to talk about something. You need to pull from something, right? And if you don't have work experience or internship experience, it's kind of tricky to figure out what you can pull from. Classwork is a great example of what you can pull from. But even something like this, if you reference during an interview that, hey, one time we had someone come into the class and talk about the healthcare industry and talk about XYZ, even a little thing like that can really set you apart from other candidates. So just something to keep in mind as you kind of listen in today and think about your own professions and what you want to do with all the skills that you're picking up. So the first thing I want to talk about, though, is Florence Nightingale. Does everybody know who Florence is? Heard of her? I think I heard a murmur in the Zoom call, but she's probably the most famous nurse that ever existed. Okay, that's what she's really known for. She was really active around the 1850s. So in the 1850s, there was a 3-year war called the Crimean War. The war was fought between Britain and Russia. It was fought over the influence of the Ottoman Empire. They were both fighting to gain more influence in the Ottoman Empire. During this Crimean War, the British military had a lot of challenges. So they had a lot of people in the military who were getting sick or injured from the war, and they were dying at great counts. The challenge was that they had to get the military personnel who were injured to Balaclava in the coast of the Crimean Peninsula. They had to get shipped all the way across the Black Sea to Constantinople, which is modern-day Istanbul, for those of you familiar with the area. And then in Constantinople, there was a military hospital where soldiers would get treated for all their wounds and all their illness. Now, this military hospital was a mess. In the military hospital, soldiers were dying left and right. The conditions were horrible. And the British military leadership knew that they had to do something about it because things couldn't go on. They were just losing too many people, and there was not enough people to actually fight the war against Russia. By the way, the British ended up winning that war. So the Secretary of War in Britain at the time, they called up Florence Nightingale and said, I need some help. We need you to assemble a team of nurses and go down to Constantinople and try to figure out how we can improve this military hospital. So Florence Nightingale put together a team. They went down in March of 1855 is when they went down to the hospital. As soon as she got there, she realized the hospital was disgusting. There was a very, very poor hygiene, basically no sanitation. There's a rumor, I don't know if it's true or not, but apparently there was a dead horse in the water system. There were rodents and insects. It was just terrible. So surprisingly, more soldiers in the hospital were dying from bad conditions and illnesses than from battle wounds or injuries. That was the kind of the ironic thing about the military hospital. So guess what she did? She scrubbed the hospital clean. She built a kitchen where she could cook food, fresh food for all the people based on everyone's dietary needs. She created a laundry system so that everybody had clean sheets. She helped reduce the death rate in about half by 1 year since she got to the military hospital. So you might be wondering, why are we talking about Florence Nightingale in this history lesson? I like to start talking about analytics and data visualizations with Florence Nightingale because she's actually one of the mothers or one of the ancestors of data visualization. She was actually one of the first people ever to visualize data in an interesting way to tell a story. She wanted to illustrate after the war, when the Secretary of War was very impressed with all the work she did, right? So they asked her to document everything. So she started documenting every single event since she got there. So that, what we call that is data, right? So she started gathering data. And then she wrote a book. And in the book, she published a really, really influential visual. I'll show you what that looks like. This is the visual that she published in her book. This is a screenshot right out of her book, published in 1857, I believe. So what this visual shows is that, so this is April 1854 to March 1855, and then this is April 1855 to March 1856. So what this visual shows is this like bluish grayish area, the biggest parts of the slices. This represents all of the deaths that the military hospital had that are not related to battle injuries. The black parts of the slices represent miscellaneous deaths, and the red part, there's a little pink, it's an old book, it's faded. The red part has to do with people who are actually dying of war injuries. So ironically, at this military hospital, the biggest cause of death was from preventable causes, not necessarily due to war, and the littlest cause of death was due to war. So what she showed during this through this visual is how that progressed over time. And as soon as she arrived in March 1855, you can see the slices changing dramatically. Right, the bluish grayish parts really crunched now, and then the red parts are dropped because, as you expect, at a military hospital, more people are dying from war-related injuries and not preventable causes. Now, anybody who's worked a lot with data visualization, you can probably sense that this is a little bit skewed, right? She probably like played around with the scale a little bit in clever ways to make it look like she had a more dramatic impact than she actually did. But what's the more important part here is that she's one of the first ones who used healthcare data to visualize what kind of impact she was having and thus tell a story. And this is why I like to start this session by talking about Florence Nightingale to understand where data visualization in healthcare came from. Does that make sense? So now, fast forward to 2021, let's talk a little bit about the US healthcare system. Many of you have had exposure to the US healthcare system, maybe because you accessed a doctor over here, accessed a hospital. Many of you have never encountered the US healthcare system. So I want to give you, like everybody, a 10-minute crash course on what the healthcare system looks like. It's not great. This is a spoiler alert. Who are the players in the US healthcare system? Insurance companies. These are insurance firms or health plans that provide coverage to people for health conditions. Government. Government is a huge player in the healthcare space. They provide plans like Medicare and Medicaid. Healthcare providers, obviously doctors and nurses, they're obviously key players in the healthcare space. We also have facilities, hospitals, offices, surgery centers, radiology centers, all kinds of buildings around that you like drive around, walk around, you see all these buildings that provide care. Those are key players. And the pharmaceuticals, companies that manufacture and distribute drugs. In order to understand the US healthcare system, you also need to understand first, what do the services and transactions look like? So I'll tell you a little story. So imagine, so this is the health, this is a health plan, right? So here's a little story for you to understand how these transactions actually work. So imagine you have a patient. Her name is Sue. She works for a company called David Clark. That's actually a real company based in Worcester. They manufacture aeronautics equipment. Most people in America get their healthcare coverage through their employer, like who they work for, which is why I know who Sue works for here, which is David Clark. Usually the employer will subsidize a little bit of your health insurance premiums. That's how you can afford health insurance premiums. So in this particular case, what happens is Sue and David Clark Company together, they pay premiums to their health plan. By the way, I use the word health plan or the term health plan and insurance company interchangeably. They mean the same thing. So these Sue pays premiums to health plans for her employer, and in exchange, her health plan provides her with coverage. Pretty simple, right? This is exactly how like auto insurance works. Like for my car insurance, I pay premiums to my car insurance company, and in exchange, they provide me coverage. So suppose that Sue goes to see her primary care doctor for her annual physical. Everybody should do that once a year, once every 2 years at least. So say she goes to Family Health, that's her primary care provider. This is Family Health, her primary care provider, PCP. So she has her annual physical. The doctor spends about 30 minutes with her, checks her out, gives her prognosis, and sends her home. Now, the doctor, the Family Health PCP doctor, needs to get paid for the service, right? It's a very important service that they provided to Sue. They need to get paid for it. So what happens in this case is that the doctor bills a claim to the insurance company. Okay? He tells the insurance company that I saw Sue for 30 minutes, give me $300. The insurance company looks at that claim and says, yep, okay, we see that you saw Sue and we'll give you $300. So they remit payment to the doctor. Make sense? So during this annual physical, it turns out that Sue actually has some abnormality. Like there was some of her blood work came back and she had high cholesterol. So one of the things that her doctor told her was, you might want to follow up with a cardiologist on this. So Sue makes an appointment a week later to see a cardiologist at Family Health. This is a cardiologist. Cardiologist sees her for 15 minutes, just run some more tests, gives her some advice, and sends her home. But the cardiologist needs to get paid for it. They spend 15 minutes with Sue. They need to get paid for it. So the cardiologist bills a claim to the health plan, and the health plan pays the cardiologist. So when Sue saw the cardiologist told her that you don't really need to worry. All you need to do is eat better and exercise a little bit more than you are. All right, that's all it said. Now Sue didn't really trust that. Sue said to herself, I'm going to make another appointment. I'm going to see a second cardiologist because I want a second opinion. All right. So now Sue goes to her local health system. It's called Evercare, and wants to see a cardiologist at Evercare. This is, by the way, a very, very common story, right? This happens every day. Evercare Physician Group Cardiology. All right. So Sue goes over there. This cardiologist checks her out for 30 minutes, runs some more tests, finishes the visit, sends her home. Evercare Cardiology needs to get paid for it. So Evercare bills a claim to the health plan, and the health plan sends a payment to Evercare Cardiology. Now, in this particular case, Evercare's cardiologist saw Sue and actually prescribed some medications. They actually prescribed some anti-cholesterol medications that Sue should pick up and start taking immediately. So Sue then goes to her local pharmacy called MedX Pharmacy to pick up the medications. She called in her order, picked it up, went home, but the pharmacy needs to get paid for it. So the pharmacy bills a claim to the health plan, and the health plan pays the pharmacy for the drugs that were given to Sue. All making sense so far? Does anyone have any questions? Okay. So what the doctor didn't realize, though, is that Sue actually has an allergy to one of the medications. So a couple of days after Sue starts her medication regimen, she actually starts to feel really bad. She develops shortness of breath. In the middle of the night, she freaks out and she calls 911. So 911 is called. The ambulance shows up to her house, lifesaver ambulance, comes to Sue's house, picks her up, takes her to the hospital. But the ambulance needs to get paid for, right? So the ambulance bills a claim to the health plan, and the health plan pays the ambulance. Okay. So the ambulance took her to the hospital, right? So now Sue has now shown up to the emergency room at Evercare Hospital. This is Evercare's ER. And the physician at Evercare checks her out. Thankfully, Sue didn't have to wait very long, but they take in Sue, they keep her there for a couple hours, run some more tests, make sure that her medications are reconciled, and observes her for a couple hours and then sends her home. Thankfully, Sue's okay. But the emergency room physician needs to get paid for it. So the emergency room physician bills a claim to the health plan, and the health plan pays the emergency room physician. Now, in this particular case, this is a little bit different than the rest because Sue's now in a hospital. Whenever you're in a hospital, the hospital itself needs to get paid. The building isn't free, right? The building is there 24/7 to serve the community. The building costs a lot of money. So the building, meaning the hospital, files a claim to the health plan, and the health plan pays the hospital. So that was a double whammy visit, right? Because there's the physician that needs to get paid for their services, and the hospital needs to get paid for existing and providing services to the community. So this picture that you're looking at here, this is happening every minute, every hour, every week, every month, every year in the US healthcare system. All right. This is important to understand, not just as context as to how analytics is applied in healthcare and how the healthcare industry works, and learning some of the players, but this is also important, especially for you all, because as you can imagine, every time a service is rendered, every time a transaction occurs, data is created. So as soon as Sue went to a cardiologist and the cardiologist dropped a claim, that claim becomes data. When Sue went to pick up the drug and the pharmacy filed a claim, that becomes data. So now imagine this at scale with 10 million patients. You basically have data on medical services and pharmaceutical services that patients are getting for a population of 10 million people. And you can actually use that data to derive all kinds of insights. Where are there inefficiencies in the healthcare system? What kind of care are patients are getting? What kind of diseases do patients have? What types of drugs are patients taking? Which hospitals are doing better than other hospitals, right? This is one of the main reasons why I go through this picture, because this picture provides a pretty good overview of how the healthcare system works, and it also tells you where data comes from, all right? By the way, in some cases, the government acts as the insurance company. So the picture is exactly the same, except for where does government get premiums? We all pay taxes. So the government gets taxes from the masses. That's how they fund programs like Medicare and Medicaid. And in exchange, government provides coverage to people like Sue or people who need Medicare and Medicaid. These programs are typically constrained to the elderly or folks who are lower income or disabled or have some other special circumstances that may qualify for Medicare and Medicaid. Looking at the entire US healthcare system, this is how they're split up. Just over half of Americans are insured through private companies. 15% is insured for Medicare and the military, about 19% on Medicaid, and 9% are insured by nobody. They're uninsured. This 9% used to be about 20% 10 years ago. Now it's 9%. Any guesses as to what changed 10 years ago? Obamacare. Yeah, I think you said Barack Obama. Yeah, you're both right. There's Obamacare, but more formally known as the Affordable Care Act. It's radically increasing, access to insurance coverage for all Americans. I do want to spare a second to talk about who's getting medical care, right? Like medical care seems really specific to people who have conditions, right? Important to realize that there's a lot of different types of people who are actually getting care. Like you have healthy patients who are getting annual physicals. You have infants who have special needs. You have patients who have chronic diseases like hypertension or pneumonia or diabetes. You have frail elderly patients. We have a lot of them in America, right? Who are maintaining degenerative diseases. You have athletes. You have patients who get into like life-threatening emergencies like gunshot wounds or car accidents. You have patients who have kidney disease who are looking for transplants. There's a whole variety of people who are seeking care from the American healthcare system every day. All of what I was talking about might sound very kind of esoteric, right? And ambiguous, but actually like they're all around us. I wanted to give you a couple of examples. I don't work for any of these companies, but some of the players that we discussed recently, St. Vincent Hospital is a local health system, right? They have an emergency care, they have an ICU, they have a lot of beds for people who need to stay overnight. We have Reliant Medical Group, which is a multi-specialty physician group. They have a lot of urgent care facilities. Then you have Tufts Health Plan, which is an insurance company. They carry commercial as well as government products. So just an example of like how this more abstract concept that I'm talking about, it's not very abstract. It's all over Worcester. It's all around us. So Dunkin' Donuts has that famous tagline slogan. I don't know if you've ever seen it on their cups, like America runs on Dunkin'. Have you ever seen that? So complete this for me. If you were to say like healthcare runs on blank, what would you say? Insurance? Good guess. Well, money. All right, that's a really good guess. I'll take one other guess. Data. All of those are true. Healthcare runs on insurance, money, and data, but more so than anything else, healthcare runs on people. You need people to administer this giant healthcare system in America. And the people includes all kinds of people, like it includes obviously doctors and nurses. You need doctors and nurses to run healthcare. But you also need finance. You also need human resources. You also need data analysts, right? You also need business professionals, medical assistants, registered nurses. So remember that this is one of the biggest industries in the United States, and it needs an army of people to run it. It also kind of reminds you that there's a lot of opportunity in this area because the healthcare industry is constantly looking for people and they're constantly understaffed. And especially in the city of Worcester, there's actually a lot of companies that are constantly hiring. Many of them hire recent graduates. So these are not hints. I'm trying to be very clear that when you kind of start graduating, when you start kind of looking around for opportunities, be thinking about healthcare in Worcester because clearly there's a lot of demand and a shortage of labor supply. I'm going to spend the next few minutes talking about data and analytics and opportunities. I'm going to show you a few visuals. Some of them would be more relevant than others, but I kind of want to leave you with an impression of like what types of data we're working with, what types of visuals we have. Pay attention to the different visual aids. After all, like I know you're learning a lot of that. These are some examples of common questions that we're solving every day. All right. So anyone here like puzzles, jigsaw puzzles, or any other kind of like riddles and things like that? These are some examples. The Sunshine Medical Group, the number of hospitalizations decreased year over year, but the total cost of hospitalizations increased. So it's kind of like a riddle, right? The number went down, the number of hospitalization went down, but the total cost went up. Why is that happening? Puzzle number 2, patients belonging to Main Street practice use the emergency room more frequently than patients at the South Street practice. So 2 practices, 2 different patient populations, one using emergency room way more than another. What's going on? And then the last one here, medication costs at Sunshine Medical Group increased year over year. The number of people taking medications is the same, but the cost of medications has suddenly skyrocketed. What's going on? These are examples, but they're pulled from real business cases that we have to solve for every day. All right. So just we're going to come back to these, but wanted you to keep it in the back of your mind as you kind of look at some of the data and the analytics and the visuals. All right. So remember this visual, right, of how healthcare actually works. Think about where all the costs lie. Okay. What are the different ways the healthcare system can incur costs? This will give you an idea of who's getting paid and who's paying, right? Remember, one thing that's really important to recognize is somebody's cost is somebody else's revenue. Right? So just think about that for a second. Cost is revenue, depending on whose perspective you're taking. All right, it seems like a really obvious concept, but that's a really important concept that a lot of people don't recognize. So in this particular case, the pharmacy is receiving revenue for a cost that the system is incurring. The United States spent $3.8 trillion on healthcare in 2019. This is a pre-pandemic year. About a third of that went to hospital care. That's the big purple slice. About $1.2 trillion went to hospital care. The next biggest slice is this light purple slice, other personal health care. This is like people who are paying out of pocket for personal health care expenses in the pharmacy. Physician services, so when you see a doctor or a nurse, like a professional, physician services drive about 15%, and prescription drugs is the 4th highest at 10%. In the US, we have a very treatment mentality, right? So the treatment mentality, you use the hospital a lot, and you take a lot of drugs. It has a very treatment mentality, not so much a preventive mentality. We're trying to move towards more of a preventive mentality, trying to move away from the treatment mentality. But it's a really, really difficult culture to change. If you think about like who's incurring the cost, right? I think these pyramids do a really good job in explaining that. You'll notice that 5% of the people are driving 45% of the cost. And you see a word here that says polychronic. Any idea what polychronic means? Does anyone know what a chronic disease is?
Like cancer.
Yeah, exactly. Like a chronic disease like cancer is an example of a disease that doesn't have a cure. That's the basic definition of a chronic disease. So diseases like diabetes doesn't have a cure. Cancer doesn't have a cure. Hypertension can't cure that. Polychronic simply means a person who has multiple of those diseases. Okay, there's many people, 5% of people in the U.S. who have polychronic issues, meaning they have multiple chronic conditions. They're extremely complex, and they drive 45% of the cost because of ER visits, overutilization of care, high care variation, and non-compliance. Then you have 20% who are at risk for major procedures like cardiology and oncology. They drive about 35%. But 3/4 of our patient population in the US, 75%, drive 20% of the cost. Okay. These pyramids, these two inverted pyramids, I feel, do a really good job of explaining costs in the US healthcare system in one slide. Another interesting way to visualize this is a little creative, little kitschy, right? But complex chronic patients, 5% of the population, drive 8.2 times the number of dollars as a healthy patient. That makes sense? Now, when we think about costs, let's think about who's the one actually paying, right? In a lot of cases, the insurance company is paying, right? But not always. So let's look at these two charts over here. So this, the blue section represents 1970, 50 years ago. The green section represents 2019. So as you see in the blue section, people paying out of pocket, like me just going to get care, just paying out of my own pocket, right? Represents about 33%. So just about a third paying out of pocket. Whereas in 2019, it's only 10%. So as the government has organized itself more, as the insurance companies have organized themselves more, what has happened over time is that more of the share of costs are now being borne by the government and the insurance companies, and less share actually coming from patients' pockets. Now, this is in complete contrast to what you're going to see in the next slide, which is how much patients are paying out of pocket over time. So the blue line here is the line that's adjusted for 2019 dollars, because you know the value of money changes over time. So this end of the graph represents 1970. This end of the graph represents 2019. So in 1970, the average patient was spending $600 out of pocket. By 2019, they're spending over double that amount. Any idea why this could be happening?
Drugs or some
Prices of services increasing. That's a really viable explanation. There is one major driver of it, which is much more significant than that. Any other guesses?
increase number of patients.
Increase number of patients. This is a normalized number, right? This explains the average amount paid per patient. So you're right, there is an increase in patient population. The US population has grown over time, but that will not contribute to this particular chart. What has happened over time is that there's a new type of insurance plans that have come into the market. They're called high deductible health plans. Okay. a deductible. I don't know if you're familiar with the term deductible, but like when I buy my car insurance, my insurance doesn't kick in until like $1,000. So if I get into a car crash, like I have to pay $1,000 out of my own pocket, and then the insurance will kick in like 80% of the rest or something like that. The reason insurance companies have deductibles in their plans is because they want the patients to have some skin in the game. They want the car driver to have some skin in the game, right? Because if everything was covered by insurance, I would be very reckless in terms of how I drive, right? But because I know that I got to pay $10,000 or $1,000, like if I get into a car crash, I'll be extra careful. So nowadays, depending on what type of plan you have, you might actually spend $1,000, $2,000, even $5,000 out of pocket before insurance actually kicks in. That's the primary reason why out-of-pocket costs have increased twofold between 1970 and 2019. Has anybody here read the book, How to Lie with Statistics? Really interesting book, very old. It was published like decades ago. Recommend reading that because look at these two slides, right? They present completely different stories about out-of-pocket costs. So you can imagine that advocates on either side of the table, right? Advocates for patients versus advocates for insurance companies. They can present the exact same data, but visualize it in two completely different ways to tell two completely different stories. So advocates for insurance companies might show this. Look, the share of out-of-pocket costs have fallen dramatically over time. Advocates for patients would show this. Look, the total average dollars the patients are paying have doubled over time. So as you kind of learn about visualizations and statistical analysis, just remember, I'm sure you've gone through this already, but remember that responsible ways of showing data is really, really important because the same data can tell multiple stories and we have to understand what's fact versus fiction. Let's talk about Massachusetts a little bit, all right? So I'm gonna, bring it a little local at this point. So in Massachusetts, thankfully, incomes generally have been rising. So between 2016 and 2018, the median income went from $95,000 to $101,000 per household. That's good news, right? We want wealth to increase across the state. So there was about a 5% jump in wealth between 2016 and 2018. However, the cost of healthcare has been increasing way higher than wealth. So for every incremental dollar that the household is earning, about 39 cents of that dollar is actually going to healthcare. 23 cents is going to taxes. So out of every dollar that you're earning, 38 cents is actually your take-home pay. So despite the fact that in the state of Massachusetts, wealth is increasing, household incomes are increasing, which is a good thing, people are recognizing a very small share of it because healthcare costs are increasing so rapidly. I think this is, by the way, a really neat way to show how your dollar breaks down. Right? Again, like we talked a little bit about cost versus revenue. Depending on which side you're looking at, some side might look at it as cost, and another side might look at it as revenue. This is another, I'll probably take about a couple minutes to wrap up here, maybe 3 minutes to wrap up. This is another example of how hospital billing has changed over time. The way hospitals get paid is when you come in with a condition, say COPD or hypertension or something, the hospital will send a bill to the insurance plan, as we now know, billing for a hypertension, billing for a pulmonary disease. However, when they do that, they can actually bill different levels of seriousness, different levels of severity, because your pulmonary disease might look very different than my pulmonary disease, right? Because some of these chronic diseases have a progression, right? Some are more complex than others. So in 2013, only 3% of pulmonary disease was billed with the highest level of severity. So only 3% of the patients coming in 2013 had the most severe kind of pulmonary disease. By 2018, of admissions have the most severe kind of pulmonary disease. The lowest severity diseases, the lowest severity pulmonary diseases have dramatically decreased over time. What do you think is driving this? Why in the matter of 5 years are hospitals seeing an increase in very severe pulmonary diseases and a decrease in very simple cases of pulmonary disease? That's exactly it, right? So over time, maybe in the population, depending on the air quality and depending on your lifestyle and everything, maybe in the population something is changing, which is causing more severe pulmonary disease bouts in people. But really what's happening is hospitals are learning to code, right? They're learning to bill better. They're learning their revenue cycles more closely. So where they have the opportunity, they're now coding the higher severity ones so that they get paid appropriately. So this is another really neat visual that shows how healthcare costs have progressed over time. Let's look at pharmacy costs. I'm not going to spend too much time on. I do want to show you a couple of, I can't leave this classroom without talking about COVID-19, right? So impact of COVID-19. What this chart shows is the year-over-year growth in spending services. So up until 2019, we had anywhere between 3 to 7% growth on average year over year. And in 2020, it fell by 8%. Anybody know why? Like, why is it? I mean, COVID-19, it should be increasing healthcare costs.
Vaccine.
Tell me more. So this is 2020. Vaccines aren't available yet. Why do we have such a huge decrease in healthcare costs in 2020? So on one hand, you have, sorry? Yeah. So that's exactly it. On one hand, you have more people go to the hospital because of COVID-19, right? But a vast majority of patients who did not get COVID-19 or got milder versions of COVID-19 stayed home and avoided the hospital like it was the plague, literally, right? So many people deferred or avoided services. So as a whole, the healthcare system saw their best year yet in terms of healthcare costs, right? Of course, it was a huge strain on resources, and COVID-19 is not wished upon anybody. But the amount of healthcare cost growth in 2020 was negative for the first time ever since the modernization of the US healthcare system. Now, is that a good thing? Obviously not, because if you look at this chart that was published by PwC, a lot of the deferred care, a lot of the things that people avoided, like knee surgery, like imaging, like a preventive cancer screening, a lot of the stuff that people didn't go to the hospital for, is that a good thing? No. We're going to pay for this later on, right? As a healthcare professional, what I hope every day is that people are getting the appropriate care that they need at the appropriate time in the appropriate place. If you need care, don't avoid it. That's exactly what we're seeing here. I gave you a lot of like quantitative data. This is a qualitative data example, right? This is based on a survey of 1,000 clinicians, physicians and nurses. They were basically asked, since March of 2020, which was the peak of the first wave of the pandemic, did your patients see decreases or increases in the following? So feelings of isolation or loneliness, huge increase, right? No surprise there. I think we all know that. Feelings of depression and or anxiety, huge increase, et cetera, et cetera. Poor nutrition, smoking cigarettes, use of substances, opioids, basically all the bad things you can think of is spiked up, right? The one thing that has fallen dramatically is exercise. So qualitative data, still very, very valuable, not something that we work with every day, at least not in my job, right? But it's really, really important to keep anecdotal information from physicians at hand at all times, because they know their patients best, they know what's going on, they know what the trends are, and this is the real impact of COVID-19 pandemic, and this is really important to figure out how to bounce back from this. All right, I'm not going to go through this again. I wanted to kind of go through the business cases and how we would go about solving them over time using some of the data. I think I'm out of time here. I mean, I think that's fine, but if you need time, just okay. Well, let me try to do this quickly. So I wanted to kind of come back to the business cases because actually using some of the data slides that I showed you, I actually provided some clues as to how to solve these riddles. All right, so view these as puzzles or riddles. You think back to some of the information I showed you. Can anybody come up with an answer to puzzle number one? So the number of hospitalizations have decreased year over year, but the total cost of hospitalizations has increased. What could be driving that? Yeah, that's exactly it. So I gave you the clue with this slide, right? The severity of pulmonary disease. This was just one example, right? The exact same thing applies to diabetes, it applies to hypertension, it applies to heart failure. All of these diseases have different levels of severity. So if you're billing the higher severity diseases over time, then you could have a situation where your total volume of hospitalizations decrease, but actually your total cost increases because the hospitals are getting paid more for those more severe cases. Let's do puzzle number two. Some patients belonging to Main Street practice are using the emergency room at a much higher rate than another practice. So two practices, two populations. One population is going to the emergency room much more frequently than the other. Good question. Now, this is at the same time, right? So, I don't know, like suppose this is 2019 or 2021, I don't know, but it's at the same time. So let's assume that the environment around them is similar. So what could be driving something like that? Remember this slide. So a very, very specific population within your entire patient population drives the majority of your cost. So when we actually encountered this problem in my team, actually, we realized that some of the patients at Main Street practice, I'm making up the name of the practice, obviously, some of the patients at the Main Street practice were actually going to the emergency room 10, 20, 30, 40, 50 times in a span of 6 months. So you might ask yourself, like, why are people going to the emergency room like 50 times? And it's like almost every other day, right? Well, it turns out these patients are polychronic. They have a lot of diseases that are not well maintained. They're extremely poor. Some of them are homeless. Some of them have severe alcohol use and opioid use disorder. Some of them have unsafe family situations and home situations. And in fact, a lot of these patients feel safest when they go to the emergency room. I feel safest when I'm at home. But there are many people in our society who feel safer in the emergency room than they feel on the streets or where they live. Okay, that is a sad reality of how our society has failed a lot of people, and it's hitting the healthcare system as a result. The last puzzle, medication costs. We didn't talk about medication costs too much. Medication costs for Sunshine Medical Group increased year over year despite no change in the number of patients getting medication. Any guesses? Same number of people taking drugs, but the cost of drugs has increased. Yeah, basically yes. So there's actually, going back to the drug slide. Let me go back there for a second. There's actually two different types of drugs. There's specialty drugs and there's traditional drugs. Traditional drugs are for your common conditions like diabetes and pain and headaches and things like that. Specialty drugs are for more like rarer conditions, genetic conditions, arthritis, cancer, orphan diseases and things like that. Specialty drugs are used by less than 2% of the population, yet in 2020, they accounted for 51% of spending. It's a very, very small pool of drugs, but they make up a vast amount of dollars in the system. That's exactly it. That's a really good point. Many people who are taking these drugs have diseases that don't have a cure. So they're basically classified as maintenance therapies. I basically need to take this drug to keep on living every day. That's basically the nature of these drugs. So something like this could cause a situation where you have the same number of people taking the drugs year over year, but the costs are going up significantly. By the way, side note about drugs, the analysis of drug costs and the efficacy of drugs, how much value they're bringing into patients' lives, what's the drug worth? These are really, really important, almost like moral and ethical questions. And there's a whole kind of subfield of analytics dedicated to this. It's called pharmacoeconomics. Really, really, really interesting. I couldn't recommend it enough. Sometimes I wish I went into pharmacoeconomics. All right, so this was the answer to puzzle number 3. So you all did really well. I think like you retained the information that I showed you really well. So I'll wrap up here, but I'll kind of emphasize again, who runs healthcare, all right? Healthcare runs on people. And how do you think these puzzles are getting solved every day? It's being solved by business analysts, right? Healthcare analysts, healthcare economists, data analysts, like yourself. Many of them have gone through programs like you have. The advantage you have is that there's not a lot of business analytics programs like 20 years ago, right? So you actually are graduating with a competitive advantage over a lot of people that you've actually studied in school. There's a lot of healthcare companies right here in Worcester. So I hope like this presentation kind of piqued your interest in the industry a little bit and gave you a little bit more education on what healthcare actually is and how it runs and who needs you. I will be coming back if time allows in October with some real like raw data that you can actually play around with and do interesting things with. I'll go through that more as time allows. Do we have time for a couple of questions before we leave?
Yeah, sure. If you guys have questions, or some people over Zoom might have questions, so that you can go over.
Yeah.
So for the nearly,
Sure, I mean,
51% of the cost of special drugs, I think the biggest cost of the recently the researchers to a lot of extended cost for the specialty is the research and the research need for it.
That's exactly right. You're hitting on a really important point, which is why do some drugs cost so much?
Because I think the basic drugs are totally too much and also the time.
Yeah. No, you're exactly right. Some of the more complex drugs for like rarer diseases, they actually take years and years of research and development before you take it to market. And that's one of the reasons it costs so much. You're absolutely right. Yep. Yeah, go ahead.
I just had like a general question. What do you think like it's the cause of like the state of like the issues that we have with like healthcare problems? Is it like the hospitals or insurance companies or government?
Yeah, I mean, you asked a question that'll take a couple of days to answer, right? But I'll give you like a 30-second answer to that. We have a treatment culture here, which is extremely difficult to change. So I'm going to leave it at that. I don't know how to solve that problem, but it is a culture that we've created over time. The other thing I'll say is the US is one of the very few countries where the government doesn't actually negotiate drug prices. So you've all heard about the FDA, the Food and Drug Administration. They've obviously become celebrities since COVID-19 came along, right? Whenever the FDA evaluates a new medication, it's never on cost. The FDA always evaluates a new medication based on efficacy and other kind of generally accepted principles like quality adjusted life years that a drug can extend for a patient. Right? It's always in the clinical efficacy of the drug. On one hand, that's a good thing, right? That's what we want FDA focused on. But on the other hand, it does make US an anomaly because in other countries, most of the medication agencies, they're actually looking at both the cost as well as the efficacy. Any other questions? Do we have anything on Zoom? I don't think so. Yeah, go ahead. And then we'll wrap up here.
So like, one of the service that most students don't have an impact on their life. It is very complex. So one of the
Yeah, so first and foremost is attend things like this, right? This is a, yeah, I'm not the authority on healthcare. I've just been in the industry for 11 years now, but not everybody gets an opportunity like this to actually like listen in from an alumni or from an alum talking about like their career experience and things like that. Right? So attending things like this is a major step. If you took something away from this presentation, please lock it down in your memory. And again, like when you're having an interview with somebody, right? You can't pull from healthcare work experience. You just don't have any, right? But you can pull from a classroom experience like this and talk about like, okay, this one time this guy came in, talked about this. That means a lot to an interviewer. Other things you can do is you can actually proactively start learning a lot more about the healthcare industry. If you're interested in like reading materials, weekly publications or monthly publications that you can read in order to like start learning a little bit about investments in healthcare or medical care or medicine in general, talk to me and I can give you some recommendations on it. You can find me on LinkedIn, by the way. If you look up my name, Ifrad Islam, pretty easy to find on LinkedIn. Yeah, you're good. Yeah, okay, yeah. So I didn't actually talk a lot about Optum. But Optum is part of United Health Group. United Health Group is actually the 6th largest company in the United States. It is massive. We have about 300,000 employees. Optum is a segment of United Health Group that provides healthcare services like information technology, consulting, pharmaceutical services. We also own and operate a chain of doctors' practices across the country. So we have physician practices on the East Coast, parts of the Mountain West region, parts of the North, and the West Coast. So that's what Optum does. For non-healthcare folks, Optum is often recognized as a logo in Gillette Stadium and Fenway Park. If you ever go to a baseball game or a football game, Optum is a big sponsor of the Patriots and the Red Sox. My particular role, which I didn't talk about too much, is I run a team of consultants who basically provide data analytics and informatics support for all of the doctors that we manage. That's my particular team. All right, so I think with that, I'll wrap up here. Thank you, Professor Hamid, and thank you all for all of your time. Thank you.